Good evening, everybody. We have got about 12 participants already, and Dr.
Yeah.
Gore and Dr. Dibakar are here with me. So let us officially say that we have started the meeting.
Yes.
It's the first inaugural meeting, and for many members, they are joining a Zoom meeting for the first time. Dr. Gore is very experienced in conducting such meetings, and I am still learning. Me and Divakar are learning because IAS courses, IAOS courses are going full swing for the last couple of Sundays. As Dr. Gore said, we should lay down certain ground rules, and Dr. Gore is typing them. This is an open session, meaning we can all ask questions. I will give a very short introduction, and by the time Dr. Gore types the questions, this DSCB or physiological pain portals technically came into existence many years ago, more than 10 years ago, when Dr. Gore first published the Gore test. So that was a landmark paper which set the ball rolling, and many people put their thinking caps and they could explore the situation. Thereafter, Dr. Divakar described his J block, which is the first web space block, and that caused revolutionary results world over. So much so that, to my knowledge, about 500 surgeons all over the world are using it for shoulder and elbow problems. And as time went by, people have discovered or stumbled upon more useful portals. And starting from pure neurological palliative procedure to fracture management, this has come up to a very great extent, and newer developments are happening. So, Dr. Divakar is here, Dr. Gore is here, and I am here. We can all share our concerns, learn from each other, and try to understand and explore this subject further. Before we start anything, I would like to reiterate what Dr. Gore always says regarding any pain management protocol, and this fact is also emphasized by Dr. Divakar. Pain is a protective phenomenon generally. In most cases, it is body's response as a positive response to the cause. And eventually you must realize that pain is just a symptom. This DSCB blocks, as we are using for pain relief, primarily treat the symptom, does not treat the cause. And the most important thing here is the diagnosis, capital D. So do not keep on depending or giving repeated injections until you have had some vague idea of the diagnosis, and over a process of time get a definitive diagnosis in hand, so that these portals become a reasonable scientific option and not a mumbo jumbo or a quack's magic wand. Dr. Divakar, you can add a few words, and then we will give the stage to Dr. Gore, who will explain the rules of the game. And we have already got how many? About 15-20 people have come, and more are joining regularly. Let's see and hope and teach and learn from each other. Yes, Dr. Divakar.
Yes, welcome to the first session of sodium channels. I would like to add here that sodium channel is the most probable explanation. We have no laboratory or no method to test that this is the only way that these things act. We have found the gravity first and explanation later. Although gravity's explanation is still not found what it is, but it exists. That's what we have discovered, that such injections, they exist, and most probable explanation previously was blocker of sodium channels. But recent shift of these injections in traumatology led us thinking that there is something else also. Those receptors present in fascia and muscles and periosteum. So we have found some common receptors which affect cannabinoid system CV2 and sodium voltage gated channel NAV 1.7 and 1.8. So this is most probable explanation. Some scientists will work in future and he will tell whether it does or not. But till date, because of the action of the xylocaine is on sodium channel, so we assume that sodium channel is the most important pathway of the action of these injections. Apart from some other channels are working, and we will search, and you will also help us to search what are other mechanisms of actions. But definitely, whenever we are injecting near nerves, the sodium channel blockade that do work. So the new systems, now this is the SCB, we have given correct name, distal channel block. So distal channel block includes sodium channel as the undiagnosed channel either two. So this is how we start, and the more questions you ask, the more explanation will be given. Thank you, Doctor.
Dr. Gore, please.
Yeah, I have a few points to make. Number one, I started working on this way back in 1996, and initially I noticed that when you are dealing with neuralgia, the nerve is tender to touch. Then we could find on palpation the distal ankle related spots which were noted to be very tender, in addition to common peroneal nerve behind the knee. Then when we realized that the nerve is tender, we went through steps where we could confirm following things. Number one, the nucleus pulposus in a disc commonly and all other inflammatory cytokines give rise to upregulation of sodium channels. Number two, local anesthetics, which are sodium channel blockers, when injected around the origin of the nerve, can relieve the pain. For example, spinal anesthesia or a block in the foramen. Step number three, we started injecting distally. Initially, we started injecting at the knee, just behind the head of the fibula. And then we realized that we need to go to the end of the axon where we can inject and we can achieve the same result. So that's why we started injecting the distal most point. The next point is, when we were students, we were told, especially related to the spine, that the primary indication for surgery was progressive neurological deficit. All of us would agree that as times have changed, the primary presentation and indication for intervention has come to be unrelenting pain. So we need to be much more attentive to the patient's narration and a diagnosis of pain. I would emphasize this single point today, that all of us must diagnose the pain. There is a small issue in that. The issue is, commonly as an orthopedic surgeon, when a patient presents to us with painful area, for example, trochanter, for example, lateral edge of the patella, for example, heel, all these years we have been only emphasizing the local causes. We have never ever had a thinking background for the referred pain or for the neuralgia, which commonly forms the basis of the pain. The same thing applies to shoulder pain, lateral epicondylar pain at the elbow, and even ulnar collateral pain commonly seen at the wrist. The point which I am trying to make is, we need to be much more aware of the diagnosis where the nerve may be involved in addition to the local cause. And I, for one, I would go to the extent of saying, with almost 37 years of my practice, that if the pain is not traumatic, not infective, or ischemic, it has to be neuralgia. There is no other cause in the human body which can give rise to pain. So I will close now, but I will just say one thing again. A diagnosis is absolutely important, and then comes the management and counseling and blocks and discussion about all that. Now we can open up the questions. The rule is simple. All those who want to ask a question can put it in the chat window, which is there on the right lower aspect. You have to click on that and go to the chat, where you make the chat for everyone, not addressed to the person. And you write question for Dr. Arvind, or question for Dr. Prakash, or question for Dr. Gori. And you say, what is this? Once the question is taken up, you unmute yourself. You can be live on your video, and then we discuss that point. Till that time, we remain muted. All of us remain muted as far as possible, so that there is no disturbance while the proceedings are on. So let us start.
Any questions? We seem to have more listeners than speakers. Or do you want some warm up so that we know what's happening?
I think we can ask questions now. I will ask a question, one simple question. Okay, there is already a question. How many injection and what interval? I think one of us, one by one, we can answer. I think Dr. Arvind, you can start answering. How many, and the question I'll read again. How many injections and what interval? Dr. Arvind, unmute.
After, yes, now, after you advise to change the names, previous names, A, B, C, D, E, F, G, H, they were a little bit confusing, L1, L2 and all. For leg, previously we named it as L channel, and that was confusing with the leg. So we changed name to Greek alphabets depending upon the site. So the first injection initial to start will be named alpha, and we labeled that distal to proximal. Alpha 1 is the most distal, and the next one will be alpha 1, alpha 2, alpha 3, alpha 4, alpha 5. They will be going to the proximal. Same thing, second name we have given beta to the leg. Beta 1 start from the distal and going to the proximal to beta 6, beta 7. And third and fourth addition recently, so we have given new name because the whole upper trunk body is known as torso. Trunk is torso in Greek, and the word for the torso is tau. So we have labeled as a tau block, and we have different injections 1, 2, 3, 4, tau 1, tau 2, tau 3, tau 4, and then injection in the head or cephalic. So we will call it kappa. The kappa 1, kappa 2, kappa 3. Same way, the other orders we will discover and we will give name. We have only 4 different names with 1, 2, 3, 4 symbol. So now some new additions in the portals, Dr. Prakash will tell you. And these injections, I am more focused on traumatology. And Dr. Gore, he is very specific about neuralgias. I think he might not be dealing with the trauma.
I do, but less, very less.
So I am focused on the trauma, because in trauma, effect is instant, visible and wonderful. And this has changed the way the child or patient present, that we calm them immediately by some of the portal block in every fracture. So I am focused more on trauma. Dr. Gore very much focused on neuralgias, and he is working on neuralgia since long, and we learned a lot of things from him also. And Dr. Prakash is in between. He is taking signals from me and from Dr. Gore and combining all these things. Thank you so much.
Today, I'll share you my experiences. 2 very interesting things happened. Number 1 was one patient with corona diarrhea and acute abdominal pain came in and we used Dr. Divakar's Tau 3, Tau 3B, umbilical and infraumbilical portals. In 10 minutes, the acute abdomen sort of disappeared and the patient was smiling. The one on the stretcher got up and started walking. At that time, my physician brother-in-law asked me, what is this you are doing around belly? I only see anti-rabies injection vaccine being given in the retroperitoneal area. So what exactly are you doing? So I told him one of my friends has described this portal for acute abdomen. At that time, a patient with diagnosed as viral gastritis, severe pain, who was in his OPD, and my brother-in-law started studying on this patient, and much to our surprise, it worked there also. At that time, I was discussing with Dr. Divakar, who told me about Tau 1 portal, which is mid-sternal portal, which is said for primarily fracture ribs. We had a patient who was suffering from somebody's phone somebody's audio is not on mute. I can hear background. Please mute your audio.
Please mute yourself. Please mute yourself, except the speaker.
Somebody is talking on the phone. It's causing disturbance.
Dr. Prakash, you mute everyone. Only the speakers will unmute themselves. You can mute everyone. You're the host.
I'm trying that. Yes, done. So now, one patient, he was severely asthmatic, probably going into status asthmaticus, and we were all planning to get ready. And I am an orthopedic surgeon. I don't treat asthma. I don't treat status asthmaticus. I have not even gone to the hospital for the last 3 months because I was worried about the corona. I had gone today to reduce a fracture, supracondylar fracture. And while I was walking through my brother-in-law's chamber, talked to him, only I saw this patient. And while they were readying his drip and other treatment, oxygen and nebulizer, I just gave one jab as Tau 1 block, which is mid-sternal. And much to my relief, whether it's placebo effect or the block worked, I don't know. His breathing eased, his gaspings and panting stopped. And a little later when they came with the nebulizer, he was no longer moving towards status asthmaticus. So today what I realized was, Dr. Divakar has taught me 2 new things. That this thing works for a diarrhea or acute abdomen as well as asthma. But my brother-in-law cautioned me that this is a dangerous double-edged sword. We must not use it until you are certain of the diagnosis. Imagine somebody with an acute appendicitis, almost about to perforate with an acute abdomen, and you give him a paraumbilical block and make him pain-free, your block is going to kill him. So, when the pain is a protective response, please don't camouflage it. When you reach to the cause of the pain and you know how to tackle it, or you know that you don't need to tackle it, then and only then you must use these portals. First question was, how many injections and what interval? I and Divakar differ slightly on this. I always use a cocktail as my first injection because I feel that its effects last longer, and many times a single injection is enough. However, Dr. Divakar uses only 0.5% lignocaine. With plain 0.5% lignocaine, you can repeat the block every 5 days and go on repeating 4 or 5 times, beyond which, if it doesn't have an effect, the pain, anxiety, pain cycle will enter in and these blocks will no longer be effective. If you are using a cocktail, do not use the cocktail itself more than once. You can follow up the cocktail by 1, 2 or 3 injections, but I would restrict to 5 as a number of maximum injections. Second question was by Dr. Kaur. This will mostly work for Dr. Divakar. He asked that use of DSCB in tennis elbow and frozen shoulder give good pain relief. But how does it work? Please explain. So Dr. Divakar, please explain.
So the explanation lies somewhere in between these two channels other than sodium channels. As he has asked that complex regional pain syndrome also. So for complex regional pain syndrome, it is definitely curative in 3 injections. In 4 or 5 patients I have treated, those who had collisis fracture and developed CRPS, they were dramatically relieved. And also, this injection is working for maluniting untreated collisis fracture. When I ask the patient whether he wants surgery to rectify it, they say, no, I don't want surgery. I said, okay, you go ahead with the malunion, give them injection, they are burning pain, CRPS and the pain of the fracture, all 3 are going in same time. And as I have told previously, that I don't mix 2 therapies. If I am giving a portal injections, I don't give even paracetamol. That is the only thing. I give them portal injection, ask them to come every 5th day until it is cured. Most of the people, they are cured within 3 injections. Some people, one sciatica patient, he was a milkman, he took about 15 injections to cure. And after cure, because for last 3-4 years he was taking treatment with various places, he tore away all the files and MRIs, and now he referred 10 more patients to me. So now, how does it act? It acts probably through CB receptors, blocking fracture pain immediately, and clavicle fracture and tennis elbow pain. For tennis elbow, this is not 100% reliable injection. 50% response. 50%. Yes, next question.
The next question was, what is the percentage of anaphylactic reaction and how do you manage anaphylactic reaction? This was actually Dr. Gore had taught me long back that it is not xylocaine that causes anaphylactic reaction. It is an additive, which is a preservative added to xylocaine, which causes anaphylactic reaction. And to prevent anaphylaxis, the best way is to use xylocard or cardiac xylocaine. However, the problem with xylocard is, once you open the vial, even if it is refrigerated, there is a possibility of fungal infection and clouding of the solution because it does not have a preservative. It just has plain lignocaine and sodium chloride solution. Dr. Divakar solves this in 2 ways. One is, instead of using a whole vial of 20 ml, buy small ampules of 2 ml or 5 ml, use appropriate quantity and throw away the rest. Otherwise, Dr. Divakar says that instead of 0.5%, give to 0.3%. And recently I have seen in his video that he has diluted and kept something like 200 ml of solution in his clinic in a huge saline bottle, from which he will keep drawing continuously for all his patients. I do not have a workload of that large numbers, so I don't need to make such dilutions. So either dilute and use or use xylocard. Dr. Gore, please.
Yeah, you see, I personally feel that the question of anaphylaxis with injection of xylocaine is one, but more often we see people who are in extreme pain and their sympathetic system is overworking. And when you give a block, when there is a sudden relief of pain and vasodilatation, many times patients go into sort of hypovolemic or vasovagal or whatever name you give it, because there is no specific name for that, but there is a definite sudden drop in blood pressure and there could be bradycardia. This is not anaphylaxis. And as you have rightly noted, if you use xylocard, the chance of getting anaphylaxis is almost zero, Because as you know, in cardiac arrhythmias, we use Xylocard IV. There is no question of testing, etc., etc. So there is no way it causes any anaphylaxis. The main problem is, which I have seen in my practice, is when you are injecting somebody who has severe cervical radicular pain, and you inject in the first web space of the hand, and then you relieve the pain, many of these people faint. Many of these people feel very giddy. They feel hypotension and maybe bradycardia also. So the best way in that case is always inject when the patient is lying down and have adequate measures, especially like head low on the bed or head low on wherever the patient is lying. In addition to, of course, if necessary, a IV fluid as to improve the volume. Otherwise, using a diluted 0.3 or 0.5 is a perfect idea. That way you can use more volume also. Now, just to set one point which Dr. Arvind mentioned, correct, there are groups in the world who are working on sodium channels. I know for one, a group in London called the London Pain Consortium. I was in talks with them about detection of sodium channels in a patient. The problem is it cannot be detected percutaneously. I mean, there is no easy detection of sodium channels in the OPD. We may have to have certain tests. Like, for example, in diabetics nowadays, they do testing and estimation of TNF alpha. And some of them, they also test sodium channels. But practically, I would say it will not be possible to detect sodium channels. For practical level, it may still remain a hypothesis, even though it is well supported in the literature. Yeah, we can go for the next question.
Yes, I said one thing, Dr. Prakash.
Yes.
What I had seen, 0.3% xylocaine is working as anesthetist also, and no reaction whatsoever is seen. But Dr. Gore has opened my eyes. I used to see hypertension, and I have had a habit of injecting adrenaline in all cases. Then I found that there are two types of cases. The one who is having bradycardia, he does not need adrenaline. He is having that sympathetic blockage, parasympathetic stimulation. And those who are having 3D pulse drenching, if the person is passing urine, understand it is a severe anaphylaxis. If he is passing too much of sweets, it is medium anaphylaxis, or hives and urticaria and breathlessness. It is sort of medium sort of anaphylaxis. So anaphylaxis itself is so rare, I have seen only 3 or 2 cases. But as Dr. Gore has told, that sympathetic blockage that gives hypertension, it is very, very common. And that's why I use atropinize before giving such injection in almost all cases of fractures.
There's one more comment which I'll make. There's one more comment which I will make, and the comment is, in many of these patients, if you are very, very observant, you will find that after our blocks, the limb temperature goes up as high as 3 degrees as compared to the other side. Especially in the lower limb, I have seen this multiple times, that the skin temperature for that lower limb may rise by almost 3 degrees centigrade. It is worthwhile making a note of this change in the temperature, which will support our hypothesis or observation that the sympathetic system is involved and is taken care of. It is something similar to a sympathectomy which we used to do in the past for TAO or other vascular problems. So it could be a good idea to use it in those patients where it is very mild. Now I think we need to go to the next question, which...
Migraine. Next
Yeah.
question was, what is the portal for migraine? This is again one of the earlier Divakar portals, and I have tested it on my sister also. This is called mid-frontal portal or the Bindi portal, or this spot. There is not much space to inject there. So 2 ml is enough. You have to jab the needle right up to the periosteum of the skull When the needle hits the bone, withdraw a little and inject 1.5 ml to 2 ml. That will already cause a nice bulge like a lipoma on the forehead. And then using wet cotton gauze, rub it nicely. It gives dramatic relief. There is another dialogy portal which we are calling as caput 2, which is 2 centimeters above the earlobe. Here, that is useful for contralateral one-sided migraine, which means if you have a left-sided migraine, you inject on the right side. If you have a right-sided migraine, you inject on the left side. It looks very strange and surprising. We don't know how they work. But for intractable migraines not being treatable by physicians who even tried morphine cogners, one caput 1 block and caput 2 block opposite to the side of headache seems to produce dramatic relief. I have just tried in one case. It worked for me, but the patient trusted me so much. I do not know whether it's truth or placebo. Here I have a feeling there is a great placebo effect also associated with DSCB, because the patient comes to you after a lot of build-up by others, hoping for relief. And if you are a senior person like me with a lot of grey hair and some reputation, the mere fact that you are present with the patient itself takes away 30% of his pain. So being a scientist, I simply cannot make my decisions on 1 or 2 cases. I can only share observations. But as you all know, I am an obsessive bookkeeper or a document keeper, and I always keep diligent documents and review them. So in few years' time, I should be able to give you answers. Dr. Gore wants to say something? Yes, Dr. Gore.
Yeah, I would say that the point which you have touched just now is extremely important, especially when the patient is in pain. The patient is seeking external validation of his symptoms. That is, he is really suffering. And number 2, when you relieve the patient of whatever that patient is talking, I mean headache, back pain, leg pain, knee pain, whatever. And once you relieve the pain, I have seen umpteen number of people using these words. They say, you are the first doctor who has understood my pain. Now, even if you don't relieve me permanently, I am happy because somebody has understood my problem. And this is very, very important in today's world where unfortunately many of our colleagues are report obsessed. They cannot diagnose a clinical condition based on clinical examination and listening to the patient. They would like to do vitamin D and B12 and some funny oblique X-ray and some bending X-ray, etc. Now, I for one, I tell people that I'm not against your investigations, but please try and increase the patient's belief in our science and not laboratory and investigative facilities alone. So trust of the patient is extremely rewarding, and I have observed in my patients who have chronic back problems, they stay with you for a long time. They don't go on shopping after they have been diagnosed properly by you.
One more thing I'd like to add. It is already existing for migraine to apply local xylocaine, 5% ointment, opposite to the upper second molar. Yeah. This is the first thing I have read about this about 20 years back. And I had been using this local xylocaine application over the upper second molar opposite on the cheek. And I started injecting xylocaine also there. But at that time I was not trying out these channels. And one more thing, that 0.3% xylocaine is working everywhere except digital block. You need 2%, no less. If you use less than 2%, the digital block is not working. So in the toe also. This I learned recently that only 2% work.
There is another area which few of us do come across is post-herpetic neuralgia and local patches of lignocaine, which were available even in our country from Zydus Cadila as Lidoderm, were very effective. I used to ask patients to cut them in a postage stamp size piece of that paper and stick it to the distal area. Unfortunately, it is not available off and on, and that is a good remedy. I mean, 5% lignocaine locally as a skin patch is very effective in selected patients. Yeah, let's go for the next question.
Next question here is, what about the white patches at the injection site? This I can answer personally, very simple. With plain xylocaine, you will never get white patches. With Kinocort, the possibility of white patches is there, but less than 10%. And with Depomedrol, 80 milligram, it is 30%. Depomedrol 40 milligram, it's about 20%. Depomedrol 10 milligram, it is about 10%. So depending on the type of steroid you use and the volume or dosage of steroid you use, you have to tell the patient in advance. There is a small possibility that you may have a postage stamp size Australian map at the site of injection of slightly paler skin, which is primarily because of the disturbance of the melanin mechanism and melanotoxin mechanism at the subdermal area, which is not an expected effect of our DSCB, but it's a side effect of the DSCB. Apart from cosmetic disfigurement, it does not cause any problems. If you have already forewarned the patient that such a possibility exists, there will be no troubles. If you have not told this to the patient, or if you yourself are not aware of this, then you may have some trouble explaining it. So I sort of even give it in writing in the form of a consent that some side effect of DSCB will be rare chance of anaphylaxis, though if I am using only Xylocard and local skin discoloration or eczematous patch. Though I have never seen an eczematous patch, let us work it out. Any thoughts on this, Dr. Gore or Divakar?
I have a side comment. The comment is when you see a patient who comes to you with a skin patch, I mean, paler skin at the site of likely injection which you are going to give, you are actually better placed in counseling the patient because you already know that the patient has taken a steroid there subcutaneously where the melanin formation, etc., has been disturbed. So you can be in a better position to counsel the patient by telling that steroids per se have no role in relief of the pain. Per se, I'm saying. I mean distally. If you inject it at the site of inflammation, it is okay. But if you have shoulder pain and you inject steroid in the first web space of the hand, I don't think it is going to have any effect on the shoulder pain. The lignocaine part of it will have. The other thing which we have to explain to the patient is, I'm sure all of us have observed, when you combine lignocaine with steroid in an intra-articular injection, I'm saying something off track, but this is important. You combine steroid with local anesthetic and inject intra-articular, you find that the pain increases for about 48 hours time. The patient is actually cursing you for first 24 hours, then of course the problem goes away. This also is a point in counseling because it does affect most of the people who take steroid plus local for intra-articular. Yeah, we go ahead, Dr. Arvind.
Next question been asked is, two questions have been asked, one privately to me and one on the group. One was for trigeminal neuralgia, which DSCB get, and second one was for neuralgia parasitica, which DSCB get. Neuralgia parasitica, I have treated a few cases, so I'll quickly answer that. And for trigeminal neuralgia, I'll give to either Dr. Gore or Dr. Divakar. Neuralgia parasitica is a case where on the outer lateral side of the thigh, patient will point his index finger in a specific geographical area and complain of burning, numbness, pain or irritation in that particular area which should be overlying the lateral quadriceps. This is an irritating symptom for which you do not find any diagnostic validation which will help you to say that because of this investigation or this X-ray or this MRI Now this blood test, the patient has got neuralgia parasitica. In the past, they were treated even with antidepressants and pregabalin. We have found that beta 2, beta 3 and beta 3AB blocks, which means one is Dr. Gore's block, posterior side of lateral malleolus. One is first interdigital, which is great toe and first toe, and second is first toe and second toe. You block these three and neuralgia parasitica gets a dramatic relief. I have got about 8 to 10 cases. I have not shared it with anyone, but I was looking through the files this morning when we were discussing about this meeting. That is my personal experience. Dr. Divakar and Dr. Gore. Dr. Divakar first, neuralgia parasitica and trigeminal neuralgia.
Neuralgia has been caused by the neuralgia and Compartment Syndrome. They are due to mucinous deposition in the tunnels, in the inguinal ligament as well as in carpal ligament. So whenever you see Compartment Syndrome and neuralgia parasitica, you always test for the thyroid. TSH alone is enough. T3, T4 is of no value. You know, the latest Love and Valley tells that T3, T4 are obsolete tests. They should not be done. You should do only TSH, and if at all further investigation needed, you should do FT3 and FT4. T3, T4 are not valid tests according to new Love and Valley. So test thyroid. If it is there, you give Altroxin and the neuralgia goes away. At my place, I found 99% of neuralgia, they came out with thyroid. And in fact, I do diagnose thyroid just by the presentation of neuralgia. And I have not injected, I have injected 1 or 2 cases, but I didn't find relief with these blocks. So I'll have to find new portals. The new portal which I discovered, now I'll test. The old portals have not worked with me because hypothyroidism always works, so I did not worry about it. Dr. Gore, please.
I have personally no experience about treating trigeminal neuralgia. I hardly have seen patient. I mean, I have seen patient, but I don't treat. About neuralgia, I have 2-3 different comments before saying what I do for them. Number one, when we are talking about symptoms, the symptoms which are related to nerve dysfunction could also be itching. I mean, a lot of patients present with itching in a particular area where the nerve is affected, and scientific literature supports this statement that itching is a manifestation of nerve dysfunction. Number two, if you talk about the nerve, if it is a mixed nerve or if it is a pure sensory nerve, the manifestations are different. And I, for one, I would prefer to inject locally at the spot, as Dr. Prakash mentioned, which the patient would indicate by the index finger around little bit closer to the anterior superior iliac spine, maybe little lower and outwards, where I would inject with Zylocard or Lignocard. But itching also is a very, very common finding in many patients, and they are surprised to see that itching goes away once you treat the nerve. Apart from, of course, their skin consultations and taking antihistaminics and all that.
Neuralgia is so common with neurologists. I have been sitting with my friend at neurology center, almost 10 cases in a day, although we see hardly 10 cases in a year. And my friend, neurologist, he's seeing 10 cases in a day.
Yeah.
So it's quite common there. I'll have to teach one of the neurologists. He will tell me better.
One question on the group plus 5 or 6 private messages to me. People want a rough chart of the various portals. I want to know what the various portals are and this terminology. So with permission of the other 2 speakers, I will monopolize this for 10 minutes by quickly, I just made those slides today for forthcoming course talk. I'll just run through very quickly. Later on I'll make a PDF and post it on the group. We are at 8:20, I'll finish by about 8:26 and then we can ask other questions and wind up the meeting. Let's just go very, very quickly about what these are. There we go. Hey,
Need to
chocolate.
mute the dog.
Yes,
Mute the
yes,
dog.
yes. She's screaming at a cat. There we go. So we go fast. So the number one, alpha portals are upper limb portals. Alpha 1 portal, that's alpha 1. And that's an example of a shoulder. You just see the video by the time I mute the dog and come. There's an example of a neck of humerus treated by alpha portals. The patient comes with a neck of humerus. I am directing it from here. My nurse is doing it in Chennai. After the injection, he started smiling. And then we can see finally his movements. Immediately you can see the hematoma in his hand. And forget this is irrespective of the fracture. Sorry. Wait. There, and finally this is on the 15th day. This is alpha 1A portal, and this is a colis reduction for alpha 1A portal, alpha 2, alpha 3, alpha 4, deltoid insertion alpha 5, beta portals are lower limb portals. This is a Gore portal which started everything, and this is beta 1, beta 2, and beta 2, the beta 3 portal, beta 3A, 3B portals in the interdigital areas. These are beta 3B, 3A portals. That's beta 4 portal, and that is beta 5 or calf muscle portal. Then comes beta 6, which is a femoral triangle portal, a very useful portal. And you can see this is a trochanteric fracture. I am not playing the video, I am just showing you the pictures. That is when he was first seen. He was just blocked and walked. Block was given, walked to the X-ray, and kept walking in a walker till union. No matter. Another trochanteric fracture, block and walk. So in stable trochanteric fractures, we can block and walk. There is no need for DHS, there is no need for PFN. You just give a beta 6 portal and walk the patient to union. Tau portals are trunk portals. Mid-sternal is a chest portal. That is a mid-sternal. Then mid-axillary is very useful for rib fractures, chest trauma. This is Tau 2 portal. Paraumbilical, Tau 3A and B. Supraumbilical is A. Infraumbilical is B. So these are Tau portals. This is sacroiliac or pelvic portal, which is useful for pelvic fractures. Left and right. That's the spots. Kaput portals or head portals. That's your Bindi portal. Middle of the forehead. And that's your temporal portal above the ear. These are the three important slides. First, you are encouraged to study human anatomy. Please think out of the box. Find new portals. Experiment. Share with us. These DSCV blocks are opening new vistas in pain management. They are game changers in fracture pain management. They are extremely useful for ergonomic fractures and work in a diverse set of situations. So, as we had said earlier, somebody wanted charts. So I'll make a good PDF, high quality PDF, and post it on a drive and share the link to the group. You can make charts, you can make printouts. Color Xerox cost 10 rupees a page, and you can hang them wherever you want, and it will be a pleasure. So this is special answer to Pawan Kohli and Dr. Muhammad, Dr. Kasif, and Dr. Kishore. This is wanted by 4 people. Now Dr. Gore.
Yeah, my comment is you have summed it up very well. I have a comment about beta 5, which is mid calf in the upper part of the calf. This is a very, very important point. On one side, if you see patients who have lumbar canal stenosis, which is very common with the aged population, they always have pain in the calf, even at night, enough to disturb their sleep. And I have seen umpteen number of people who have tried probably infinite combinations of medications, which don't really help. On the clinical side, if you press very deep on the mid calf, in that area, which is beta 5, the patient has severe tenderness of the posterior tibial nerve. This is indicative commonly of L5S1 related stenosis. In addition to treatment of stenosis, this could be a simple way of treating that calf pain or resistant calf pain or obstinate calf pain. Number 2, as I had mentioned in our program last time when we had in Chennai, I have designed a electrical percutaneous electrical nerve stimulator, which can also be used at these various portals. This is a small size stimulator which is controlled by a mobile app. It contains a battery inside. We are trying to see if we can reduce the size of the battery so that the applicator or that stimulator will become very small. And this can help some people where maybe giving repeat injections may not be practicable. Or I use it in very, very aged people, let's say above 75, who are not very mobile, but they do need good pain relief. So this could be one more addition. And if somebody wants more details, we can always, I would circulate some more details about it very soon.
This is a very, very important point. I have seen the PDF sent by Dr. Gore, and I had also imported a few of these from China and distributed them to my patients. Dr. Gore has done a very good job in getting a good quality stuff at a very low price. And I think Mission Spine is in the process of distributing it to their patients at a very, very low and economical cost. I would request Dr. Gore to post the details on the group so that members who want to buy it for their patients can buy it from Dr. Gore. It is very inexpensive and does not cost, it costs much less than 1 year's course of analgesics for a patient with any of these chronic pain, and can be used by more than one member of the family, all controlled by a mobile app. It is one of the newer generations and newer dimensions of pain management which should be useful in future. Dr. Divakar.
Yes, now these blocks are working in sympathetic system. It is very much seen that it has cured hyperhidrosis of hand in 3 cases. Single injection giving relief 3 days, next injection giving relief for 10 days, and third injection patients they did not return. So hyperhidrosis control is a clear sign that it is working on the sympathetic system. And another is Buzzard's disease. Although my cure is different, but immediate relief is by beta 2 or beta 1 portal that gives immediate relief lasting 3 days in Buzzard's. And I think all of those who have treated Buzzard's, they have seen that Buzzard pain is so severe that patient is comes to you crying. He has used all the injections. And lumbar sympathectomy. I was teaching to the PG aspirants in 2000, and there was a question in that lumbar sympathectomy is of any help. The answer was no. Lumbar sympathectomy does not help in Buzzard's disease. That day I realized that Buzzard's has some other diagnosis, and that I found later that it is very well treatable chemically, and cure within 2 months. And I have many patients of Burgers, those who restarted smoking without aggravation of disease. So Burgers have a cure also. But immediate relief, the patient, they literally fall on their feet. You give them beta 2 injection and the pain is instantly gone, which is lasting. I have one patient from Sanjay Gandhi PGI who had been treated by multiple toe amputation for 3 years without pain relief. He was relieved within a second. So sympathetic system is one of the very important part of these DSCBs.
I think we almost exceeded an hour, so we'll have to come to the end of it sooner. Just one or two observations in line with what Dr. Divakar said, and then one or two questions also. Number one was compartment syndrome.
Yes.
My very experience happened 3 days ago. I have a junior orthopedic colleague in the hospital. I don't do trauma. This was a closed tibial fracture, massive swelling. He sent me the photograph of the blisters and said, I'm posting it for a fasciotomy at 11 p.m. tonight. Message came to me at 5 p.m. in the evening. I told him that I have not done fasciotomies in the last 15 years. Try my method. We started him on Medarol 8 milligram TDS oral and gave him beta 1, 2, 2A, 2B and beta 3 block, total 8 ml. The instant the blocks went in, the pain came down dramatically. With the pain, the skin circulation improved, the toe saturation, which was 83, came up to 94, and with a combination of oral steroids and this, he did not need a fasciotomy. And though I wanted to do an Elizarov, my junior colleague wanted to do a nailing, so I just didn't go to the hospital, allowed him to do the nails. We avoided the nasty scars of fasciotomy. The question they have asked is, how long do the blocks affect lasting fractures? See, the point with fractures is these blocks do not work in newer pains, which means you cannot manipulate a fracture under a DSCB. For that, you need to combine it with hematoma block, which is what I'll give you in a talk. It works for existing pain. But during the procedure, if you cause something to aggravate the pain, that cannot be controlled by the DSCB. That is the difference between local anesthesia, H.
Right.
That is local blocks and our distal channel blocks. These blocks are useful for existing painful conditions. Meaning that when a patient comes to you with some pain, you give him a block from as little as 12 hours to as much as 3 weeks, the effect will last. In acute traumatic conditions, the role of these are primarily for number one, shifting to the X-ray, a shaft of femur, a trochanteric fracture, an acetabular fracture, multiple fracture ribs. These are patients in agony. Position them for an X-ray is difficult. Radiographer cannot take a proper X-ray. So, the moment you see them in the casualty, give them a block appropriately, keep the chart in your mind. It gives them significant pain relief. In a polytrauma patient, especially with head injury, where you cannot give central narcotics, these blocks are extremely useful. Once you take an X-ray, you plan the definitive management for the trauma. If you plan to treat the trauma non-operatively, like Dr. Divakar does or I do, you must give either a local anesthesia or a short general anesthesia or a hematoma block to reduce the fracture. The block that had prevented the fracture pain for X-ray will no longer work when you manipulate the fracture and produce new pain, which has to tell us something about the pathology and mechanism of working of these blocks. And if it is an undisplaced fracture with extreme pain, you give a block and a cast, the pain relief will go for 3 days, 4 days or 5 days. I think exactly what Dr. Divakar has answered, fracture pain relief for 3 to 5 days. Now I think I'll leave it to Dr. Gore to give his closing statement, after which Dr. Divakar can give his closing statement, and we will call it a day.
Yeah.
Dr. Divakar. Oh, sorry, Gore, please.
So now today I also learned from Dr. Gore that
Okay.
tender point in calf. It was a problem, Dr. Gore. I have seen people are coming with the perennial muscles pain, not relieved by anything. So possibly these blocks must help. I have a patient who has got severe perennial pain, not relieved by any analysis. I did not try blocks, but I think your block will work. Beta 5. So I think
Now,
there are many conditions from which these new blocks will help, and we exchange ideas, and I have also learned few things today also. So now Dr. Gore, please.
now, I have 4 comments to make. Comment number 1, we must be able to highlight the point that patients will come with pain and there may be associated things with the pain. One could be sympathetic hyperactivity. Second could be a muscle spasm, etc. When we give a block and stop the pain, the signs will change. This is a very important observation. The signs which the patient we try to elicit will change completely. For example, in all patients whom I see for heel pain, knee pain, groin pain, and coccygeal pain, the block will change them totally. Point number 2, which I like to make is, Dr. Prakash and Dr. Arvind, there is now a time for us to divide our blocks into trauma and cold orthopedics blocks. Point number 3 is, Dr. Prakash, we must design a simple Google form for case registry where people may be interested in submitting their inputs on blocks for a indication or an indication, and we make a big list of it, and that would lead to point number 4, that we revise our physiological pain portal book very soon. So that would help most of us and will improve our reach and significance of what we are doing. Very good.
Thank you very much, Dr. Gore. His last session is worth its weight in gold. The moment we disconnect from this meeting, I will set up a questionnaire and then I'll get feedback from both Dr. Divakar and Dr. Gore, and we'll put up the form online and we'll share it with this group plus as well as the 2 other groups, because we're running 2 pain portal courses for iOS with international students. And let us start collecting more data, because each day, like you and Dr. Gore and Dr. Divakar, I'm learning more and more. Each day I'm realizing how little I know and how much more there is to know. Only very recently, as Dr. Gore I suddenly realized that the arm, the side where I had injected, was sweating more than the side which was not injected. That happened after 10 minutes. When the patient finished the physiotherapy for his shoulder and came back, he said, "Sir, my right arm, hand and all is wet because my right armpit inside the shirt has all become wet. It is not on the left side." I said, "Baba, you have done aggressive physiotherapy." He said, "No, sir, I did physiotherapy like this. So both shoulders are moving with equal ease. Why this armpit alone is wet and this is not wet?" So that only I had some small tube light hitting. But yes, this has some sympathetic, parasympathetic influence also. And I think Dr. Divakar's explanation that there is some cannabinoid mediated response in the receptors is very, very valid. And based on Dr. Gore's input, I had even done some literature research. There is a very, very costly lignocaine Cogner or derivative, $625 for a 10 ml vial.
Yeah.
But that is supposed to last for a week minimum. For
Not
long
25, $250. $250.
$250.
Yeah,
Imagine.
for a small vial. Yeah.
And that is supposed to last for a week or 10 days. Now here we
Yeah.
have 3% lignocaine from the market costing few paisa, lasting for 3 weeks. So hopefully we are doing something right. I should thank you all very, very much for this wonderful meeting. Beautiful inputs from Dr. Gore and Dr. Divakar. and we had totally 39 participants at the peak of the talk. I thank you all for being here. I'm making a recording and hopefully I'll put it on YouTube. Thank you very much. Goodbye.
Thank you very much.